Welcome to Digital Health News. Today, in this episode, we are diving into the intersection of technology and medicine with Dr. Sanjeev Singh. Dr. Sanjeev Singh is Medical Director at Amrita Hospital, Faridabad, and has been instrumental in planning and designing this facility. In this conversation, we will touch upon the digital transformation of Amrita Hospital, how tools like clinical decision support system are shaping smarter healthcare, as well as we will touch upon what it truly takes to sight a balance between the affordability and technology in healthcare. Thank you so much, sir. Thank you so much for your time. So my first question to you is, whenever we enter this facility, the first thing one notices is how technology is not just another element, but it's an integral part of this facility. Was it a conscious decision to make technology an integral part of the facility? What was the thought process or philosophy behind starting it out?
So we are basically a university teaching hospital where we have a very comprehensive design where we need to do a good clinical work. We also need to do academics. We have to sort of do research and also touch base with the community because that's where we need to get back to the community. So there's a lot of public health. So that's a comprehensive doctor where he does good teaching, does research, he does good public health, as well as he comes back to the hospital and does clinical work. When he has to do all of this, technology is a very integral part because now most of the clinical work requires a lot of technology assistance, and you need to sort of be an early adopter. So be it in an outpatient services, be it in inpatient with operation theaters and diagnostics and imaging. In research, there's huge advancement which has happened. So you could look at new drugs, new medical devices, new processes, new point of care testing, cellular therapies, biorepositories, which are very, very advanced. And similarly, when you go to the public health, it is again becoming point of care. So if you're doing an TB program, so the X-rays could be done there, app-based clinical features are done there. And most of the tests for identifying tuberculosis patients are done at the village side, at the bedside. And then all of it could be remotely controlled. So like we have a digital mobile telemedicine van, which goes to each taluk and it is connected to us. And whenever there is a advanced consultation which is required, there's a tele-alert message and it gets connected to a cardiologist or a nephrologist. And we cover villages through that. There is a mobile mammo van. So it goes with the technicians where the mammo is done. There is a lot of public health work with respect to echo, which is being done of pediatric age group, and identifying rheumatic heart disease, which is real-time identified by the pediatric cardiologist sitting here, and then shifting for a referral base for either a medical treatment or a surgical treatment. So in totality, I think when we were planning this hospital, we went through what is required where patient is centric, and then with him as center, what all would be required so that his movement is less, efficiency is supreme, and excellence was our norm. So if he parks our vehicle well in our facility, which is also parking is color coded, he comes back to a particular department. Everything happens in that department. It's a very Mayo Clinic model where his registration, his consultation, his nurse initial assessment, his phlebotomy, his advanced diagnostics, whether it is upper GI endoscopy, sigmoidoscopy, colonoscopy, ERCP, all is done in outpatient service. His pharmacy is also there. So we have 81 super specialty departments in our hospital. All departments outpatient is like this. So patient doesn't move anywhere. Everything is done there. So with this, if the sample is taken in an outpatient, we have Asia's largest installation for pneumatic tube. It goes immediately within 18 seconds to 1 hour, 1 minute and 20 seconds from all locations. It goes to a central repository. And then from there, it goes into a track system. So we have given a very large space for diagnostics. It is all robotically governed and barcoded, and every tests can be done. It is bidirectionally converted. So once it is approved, it is available on the desktop or on our mobile app. So there's no paper. Similarly, for imaging, as soon as any advanced test X-ray, CTMR, fluoroscopies are done, we have our own picture archiving and communication system, which is a homegrown system. It is immediately within fraction of seconds, the image is available either on your mobile, our app, Amrita Swift app, or it is available on the desktop. So if it is a clinical care where the doctors are taking rounds, he goes with our app. So we have our own homegrown electronic medical record system, hospital information. He knows what kind of outpatients patients he's going to look for today, where are his inpatients located, how many critical care patients. If he wants to do a bedside lab, it's all available on the app. It for images and reports are available. And then similarly, if he doesn't know what could be a diagnosis, what is the most updated knowledge available for a particular syndrome, he looks at the clinical decision support system, which is all at bedside. So intent is that the doctor is very, very productive and he has to be very efficient. And that is how the design is, because if the patient is centered and he doesn't have to move. The doctor is so efficiently provided with it, his technology savvy, and he's been assisted that it helps us to basically provide proper patient care.
Could you elaborate a bit about the clinical decision support system that you are using and how it is helping you deliver a patient-centered care?
So there are many, many order sets. So it could be for chronic obstructive pulmonary disease. It could be for asthma. It could be for any of the surgical or diabetes management. So but the patients, unfortunately, when they come to a tertiary care facility, they are either hospitalized. Many hospitalizations have happened in the secondary care, or they are basically looking at, they come with a lot of comorbidities. So they are not very, very simple cases, because India is diverse, secondary care is pretty advanced, the government hospitals are doing fantastically well. So when they come to a good tertiary quaternary care, they are high-risk complex patients. With this complexity, when you basically go on round, you find out that there needs to be a multidisciplinary approach to a particular, multimodal approach to a particular patient. So he has long-standing diabetes, he has long-standing hypertension, he also has hypercholesterolemia, he has possibly an acute kidney injury or acute on chronic, he could have a liver disease, and then he also has sepsis. Now, with this mechanism, what would be the best treatment which can be initiated? So if I basically initiate a particular antibiotic, now I need to know whether is this the right antibiotic for this particular patient, and that comes from the clinical decision support system, because I feed in that data, because our antibiograms are there. Based on that, it gives me a pop-up of the right choice, which is not always broad spectrum. When I look at basically giving this particular, so some of these antibiotics are time dependent and dose dependent. So I just don't prescribe every drug as TDS or BD or QID, because different drug has different dose strength and duration which needs to be given. And that is where it is extremely important that it is informed well to the clinician who's rounding. And based on that, if there has to be a lab drug interaction, food drug interaction, or drug to drug interaction which is already taken, it all comes as a clinical decision support system bedside. So you don't do harm while you're prescribing a prescription, and you also are rational in your prescription. So I think that is the ethos of the hospital. One, it has to be very ethical. It has to be evidence-based. It has to be rational. And efficiently, the services needs to be utilized. So his stay cannot be more than what is expected. His diagnostics cannot be more what is prescribed. His pharmaceuticals have to be, an appropriate care has to be done. All of this support is generated through clinical decision support system, and that's the utility of it.
When it comes to clinical decision support system, and medicine is rarely black and white. So in case if the care pattern suggested by clinical decision support system, if it goes against the clinician's experience or it's his intuitions, what what is the course of action one should take in this kind of situation?
Clinical decision support system and point of care testing falls under that right now. So there needs to be some kind of a refresher which has to happen for all the faculty who basically sort of wants to participate. Many of the times it is experience-based learning or decisions. Many of the time it could be eminence-based decision, and there is no one solution to everything. One, the selections of the faculty has to be good because they need to practice science and they cannot just practice writing more and more. So it is important that you take a decent history, you come to a good plan of care, and then there are lots of other support systems like nutritionists, clinical pharmacists, and medical social worker. You seek nursing, you seek their help. And once all of it is available to you, the clinical decision support system comes as a complement and an aid to them. So when you bring in any of this at the bedside, it's not that all of them, they immediately get excited and jump and they buy this whole idea. You have to be slow, and that is where I think Julianne in Harvard Business Review had mentioned that it needs to be more transformative rather than digital. So being digital excites everybody. That should not be the aim. The aim has to be transformation. And when the transformation has to happen, it has to be with engagement of the faculty. It cannot be top down. It has to be bottoms up, where you give them time, you give them evidence, you give them freedom to adopt, because there is autonomy for the prescriber and the clinician. That autonomy needs to be sort of respected, but you also want to see that always evidence-based care is practiced. It cannot be any other way at all. For a institution of eminence, the patient should get the best care, and that is where aids like clinical decision support systems are extremely handy. But it takes its own time. So if a patient with essential hypertension would only require a test of creatinine, eGFR, and electrolytes, so be it. So other tests, which generally happens when you come in, and LFTs are also prescribed, and KFTs are also prescribed, and CBC is also prescribed, and X-ray is also done, and ABG is also done. So it need not be done because that is not required. And that is where evidence-based practice would be there. And you always start with a targeted therapy. You don't start with beating around the bush, and then you look at sort of 3 to 5 days, then change. So that is where this is CDSS is important. That is where engaging with the physicians is important. That is where just getting excited with digital technology is not fair. And it is good to just transform and take it their own time and be with them during this journey. And I'm sure every physician who has taken a noble profession doesn't want to do any harm. So ultimately, the patient outcome is important.
Absolutely. So you mentioned about the change management process. And whenever we talk to technologists who are implementing technology in healthcare organization, one of the major hurdles that they face is change management. They always say the senior physicians are not ready to move to digital technologies. In case of a similar situation, what would you suggest is the best course of action?
So change is always difficult. But if you don't change is going to change you. And that is extremely important. And that is why now the undergraduate teaching has to be very technology driven, because technology is definitely coming. Just like AI, ML, it is already there. So no longer you can keep debating whether your jobs will be secure, is AI good, is AI bad, is ethical. You need to be an early adopter. Otherwise, you're going to miss the bus, and you don't want to do that. So with that, it would be at least the leadership should be very, very open to good technologies which are coming in. But having said that, I would also like to say that there are many technologies which came in and have failed. So Google Glass came in with a big bang and then it didn't do well. Similarly, IBM Watson came up decently well for oncology, didn't do that well. There was a Microsoft, there was a prescriber.gov, healthcare.gov. There are lots of good technology which got introduced, didn't do well for various reasons. Either their evaluation was not appropriate, either the collaborations were not appropriate, either the engagement was not good, either the learning and development for that adoption was not proper. So I think it is important that one understanding why you need the technology. So for our case, in diagnostics, it's all on track system. So the vacutainers are just fed in. The robot immediately removes the cap. By barcode, his either the kidney function test and liver function test and hormonal or immunoassays will be all done. And the tests would be there within our lab information system. And just in case if the sample gets stored. Just in case if the consultant feels that yesterday the creatinine was 14 and today it's 1, what happened? He can order a redo test from his desktop. The robot, almost a kilometer away in the lab, will go back to the storage, pick that particular barcoded sample, redo the test. The intent is that skilled manpower for allied health may not be available. So can you avoid that particular cost? And then adopt technology which is going to be sort of beneficial, which is proven, and then bring it to the practice so your efficiency is better and turnaround time is better, and that would be reflective on the patient care on a daily basis. So with that, when you bring in that particular transformation, you can present that as a bouquet to all the clinical team. And I'm sure everybody wants to do best for the patient, and the best gets delivered. Similarly, for diagnostics, for genomics, for robotic therapy, for any of the advanced care, whether it is wearables, whether it is. So you bring in change with all of them getting engaged. The best science is proven. It has enough data which reflects that it is safe, it is efficacious, and then ultimately the patient outcomes is also calculated, and if it is improving, that is how you need to. It can be slow process, but that is the process which you need to adopt.
Right. Dr. Singh, but while we are, throwing all these technologies at doctors, it can certainly be overwhelming for physicians. The constant alerts, the constant insights that they are getting from technology, they have to feed the information in the system. It can be quite overwhelming for them as well. How do you sort of balance the actionable insights versus the, how they're getting overwhelmed by this technology?
So, what is the costliest equipment in the hospital? It is doctor's pen. Because he can really make and break a patient. So much so that in India, 2.3 million, because of healthcare cost, go below poverty line. And it is because many of the practices are irrational. So to your question, it is extremely important that appropriate care is always provided, whether technology is there, whether technology is not there. I'll give you an example for asthma. In Delhi, air quality index is very high. Patient comes with shortness of breath, and then you prescribe all kinds of blood tests. You prescribe CBCs and ABGs and HRCT, because that is what a good hospital should do. And then you prescribe lots of medicines. It could be short-acting beta agonist, long-acting, steroids have to be given, deriphyllins have to be given, mast cell inhibitors have to be given, anti-allergics have to be given, the immunomodulators have to be given. All of it is not required, neither these investigations nor this prescription. It is so simple that the science says, or the GINA guideline says, that it is pulmonary function test, which should be done only to identify whether he has asthma. And inhalational corticosteroid with long acting should only be given. And we give all. So, in totality, a prescription which is not good would be 8,000 rupees one time when he comes, because that is investigation and some of these prescription. A good prescription, if it's done well, a pulmonary function test could be just 800 bucks and other prescription could be 300. So it is good practice is cost effective. But that requires training, that requires willingness to learn, that requires willingness to renew whatever newer updated guidelines which are coming in. And that should be, I think, the norm. So to answer your question, it is you cannot just dump technology and ask clinicians to adopt. It's not possible. But then some of the departments are moving toward precise and personalized medicine. So if you need to do a radiation oncology treatment, which was earlier cobalt, non-linear accelerator, more advanced linear accelerator with IMRT, IGRT, 3DRT, SRS, what has happened is that all these the side effects of a toxic radiation dose which was given is getting negligible. And it also is synchronized. So with your breath, it also synchronizes. And then it is robotic in nature and it is precise. And that is where that the benefit comes to the patient. And that way, that technology needs to be adopted because it's fair. You have tested it and then it is, you have seen that the best results are available and it is the best treatment of choice which is there. I'm not talking about proton and very high end. I'm talking about just good radiation oncology which is precise. So once that is there, you always have to balance what is good and bad, what is right and wrong, and then let the clinicians choose among them and then see what works best for the patient. So in totality, it's not that it is the technology which the best of technology will provide the best of the care. It is the best of the doctor who are compassionate, who are human, who have humility, who can just go out and say, yes, I did a mistake and I am sorry. And that doesn't exist these days. Who are updated and then who are empathetic, who are just ready to listen to the patient woes because he has come to speak to you and not be just transactional because I have to see more because that is how I earn. So I think the intent of creating an hospital should be very, very clear. And the nobility of this profession needs to be retained. And based on that, if technology sort of fits in to aid, to complement good work, that should be sort of adopted.
Very well said, sir. And I think I'll come to this question with regards to artificial intelligence also at the end of this interview. But for now, I would like to ask you, as you rightly mentioned, when hospitals do digital transformation, they are on the journey of digital transformation. Many technologies are being integrated, but that also tends to, bring up the cost. How do you sort of balance between the affordability and the need for integrating new technologies in healthcare?
So our founder, Mata Amritanand May, has always said that we need to introduce technology which is very, very valid and which is sort of proven. But we should also see that the cost doesn't rise because the patient may not be able to pay. So there needs to be lots of strategies which needs to work where we have to say that economies of scales needs to work, that basically you work on a higher volume and you somehow tend to manage the cost. So it is not a very easy exercise because most of these technologies, when they get updated or it's more advanced, it gets costlier. But it's not that every costly technology is the best adoption for the patient's outcome. So you need to balance it because ultimately in India, which is a low middle income country, cost is a decision factor. And with the 68% patients who are still being rural, who are low income, you need to be providing care to them. So it would be a balancing of an act rather than just doing more and more technology and increasing the cost. We did a study. 45% of the bill does belong to biomedical care. So your question is extremely valid, because with the introduction of technology, there would be increase in the cost. Now we need to see what is the best technology and the most cost-effective technology which we need to adopt. So for doing this, it is important for the hospital to be also doing economics well, because I can adopt high-end technology, but then it may not just work. So there is a tool which is called as health technology assessment, which is a good decision-making tool, at least for the technology introduction. Now, this tool comes from National Institute of Clinical Excellence, where it basically is asking for 6 salient features. One, is there a science behind this technology? Is it cost benefit, cost effective, cost utility? Is it legal? Is it ethical? Is it for a societal benefit? And does it make a comprehensive sense? So when you always take a decisions whether new technology comes, because we have seen this post-COVID, there are lots of preprint journals. They have advised so many things. It may work, it may not work. Some did, some didn't. So science is important, and economics is important. Once that is done, and that is where ethics comes in. You always weigh other than autonomy, beneficence and maleficence, and there needs to be a justice to the patient. Because you cannot be charging him a day a penny extra, because that is where the code of medical ethics sort of comes in. So it would be a mix, but it's not that you adopt more technology and you should not pass on the benefit to you should pass on the benefit to the patient, not the cost. It's a tough decision, because but economies of scale would be something, or strategizing, have a good revenue sharing model with the vendor, have different adopt some training mechanisms so that you sort of share the cost at some other location, and don't pass on this additional cost to the patient. So there are many ways it can be done. We have done that with the robotics in our past institution and this institution. We have done that with diagnostics and advanced in this institution, and we don't pass on that benefit. So there are strategies. I think in totality, in comprehensive nature, you need to look what could be the best, where the bills don't rise, but you still provide the best of the care for the best of the outcome.
Absolutely, sir. So going back to my previous question, when you rightly said that physicians need to adopt technology, there has been a lot of chatter around artificial intelligence in healthcare, and there have been divided opinions. I've seen some people saying, going to the extent of saying that artificial intelligence will replace doctors. Then there are some who say that artificial intelligence is not going to replace doctors, because healthcare essentially is a industry which requires a human touch. Where do you stand in this debate?
So I think it is important to understand that now artificial intelligence is there. We need to pick the right tool in AI, because right now there could be at least 150, 200 vendors just working on good AI model for X-rays or diagnostics, imaging. We don't know which is standardized, because there is no mechanism right now, and which will sort of work, and then there is ethics in adopting it so that you're not going wrong. My point is that gone are the days you are unable to fight AI or no AI. You need to adopt. Now, what we did is that we have sort of made it mandatory for all our faculty to be AI trained. We have made it mandatory for all faculty to be chatbot trained. Now, I am excited to adopt AI, but what do I do? Because I don't have people. So we have started a B.Tech and an M.Tech program for AI in healthcare, which is the first of its kind in the country. So we have 100 of these undergraduates who have been taken, who are within the healthcare campus learning AI in healthcare. So they are working with the doctors. So they don't work in a separate institution which is just engineering, and medicine has there is no symbiotic relationship, so that doesn't happen. So they work in a very synergistic manner, and they talk to the doctors and see what are their problems. So now I'll give you an example. When the patient comes in, he keeps waiting in the outpatient area. So we adopted a chatbot system where when he is waiting, he is engaged, he can feed in all his information of what all are the problems which with his he came in. He's engaged, his time is getting utilized, and then he submits that information and it comes into our hospital information system. As soon as he gets into the doctor's room, the doctor knows everything about the patient who came in. He is so impressed because the doctor says, Jagdish, you are having itching, you are having an urticaria, you are having this problem for 7 months. And he is so surprised that I have just entered. And this guy or this lady knows everything. Now, with this, the confidence level goes high. Whatever time he or she used to take for getting the history from the patient is reduced. The consultation, which used to take 15 to 18 minutes, have reduced to 8 minutes. 10 minutes of the doctor's most productive person in the hospital is there per patient. So he can see more patients. He could be more productive, or can spend time in the teaching, research, data analysis, and things like that. So it's a very simple tool. Similarly, if you look at in operation theater, so if I've invested $100, my $30 goes into operation theater. It's a very capital intensive, manpower intensive area. I need to have adequate utilization of operation theater. So what should I do? I need to schedule well. When I schedule, I should know the nursing who's there, the technician, the equipments, the instruments, and all of it, my time, so that when my next case can also come in within 10 minutes of the theater. And I should also tag when did the induction start, and when the incision start, when incision ended, and when the patient vacated the operation theater, so that the next can easily wheeled in, and whether all his diagnostics and image is all available. Now, all of it could be all done with AI, and we are doing it. And it predicts, it tells us that last time you did ask for an advanced microscope, you didn't. You did ask for a C-arm. You did ask for an additional test, which it prompts you didn't. So that you don't miss and you don't keep opening the doors of an operation theater. You are all prepared. You know it's last time also 45 minutes, and this time possibly it's 50 minutes. So overall, it's clean. It's transparent, it's clean, everybody knows, and it's more efficient, and you could possibly do more case. And we are seeing this, that we are doing within the limited number of we have just started 2.5 years back. We are doing the opportunity for doing more cases is there with this adoption. So what I'm trying to say is that it is so exciting to see the utility of it either in clinical work. And we see that with the breast imaging. We could see that with the precancerous, and it possibly could be cancerous in scopies, in the radiation on head and neck. So all of it, information is available. It is in the interest of the patient. It is in the interest of the institution. It is in the interest of the clinical efficiency. It is in the interest of the safety. So it is very, very exciting times. The intent should be that let's see whether what works and in a longer haul. And I'm sure the human part of the doctor is never going to be sort of substituted, because that's the supreme thing in medicine. Because if every patient who comes in, if 35 to 40% of it is psychosomatic in nature, and when he speaks to the doctor and doctor gives him a lot of confidence, his 35-40% of the illness is gone. Now that is very, very essential and critical. So AI will help in a lot of other things, but it's not going to replace. And we have seen this with a lot of technologies which has also come in. That's a debate which I think is going to go for another decade or two.
You've seen the trends of 2024 in healthcare. What are the trends do you think are going to be there in 2025, sustaining from 2024, and the new trends that you think will be there in the healthcare industry?
So definitely AI and ML is definitely there. We have seen a lot of good work happening with augmented reality and virtual reality. We have seen that with our congenital heart, our pediatric cardiac doctor basically use AR and VR and XR, and he slices the complex heart, and that also helps the patient and the bystander and attendant to understand what is he going to do when the patient gets under the table. So there is a lot of confidence which comes in.
That also, I think, builds the trust.
Exactly. Now the same thing is used by the students, because students doesn't know anatomy because it's so complex, because from the skin to fascia to muscles to nerves and to various structure, they don't understand. With virtual, they can play. With augmented, they can play and understand the location, sagittal, coronal section, and it would be very easy for them to also remember. And that we are using that for our education purpose. So AI is definitely going to be the game changer. Augmented reality, virtual reality would be there. Clinical decision support system is there. Point of care tests with microfluidic channels and biosensors. There are lots of, right now, large labs may not be required. So it will be all done bedside, and it will be all done faster. So right now you take 48 to 72 hours for a blood culture and you wait for organisms to get isolated. It would be sort of available within 3 to 4 hours. And imagine you give a targeted therapy immediately and when the patient comes to ER. Amazing. Lot of wearable devices have come in. So we also have a command station at our hospital. Your wearable device can be networked to us, and we monitor your saturation, your heart rate, your ECG, your respiration, your sleep cycle. And imagine if there is a trigger between gastritis and heart attack, you can immediately call a patient to your hospital or refer him to another hospital. You save life. So it all is possible with command station. There is a lot of mobile health which is also coming in. There's a lot of customer acquisition and customer relationship management happening, because if your glycosylated hemoglobins have been high, I just pick and choose and shoot to the patient with information. Your diet should be like this because your glycosylated hemoglobin was 7, and you should exercise. You please do yoga and meditation, and this could be the possible things which you need to adopt, preventive in nature. And this could all be done with good prediction. So that is definitely there. A lot of complex diseases are there with spine, head and neck. It's very difficult with heart. So 3D printing and 3D bioprinting and 3D inking is again an area which is going to be there, which will be very useful, because complex cases can be, you need to have that structure, plan it well, or you can possibly regenerate and grow some of these. If if you have got a long bone fracture and you have missed some of the bone elements, you could also grow the bone cells, and that could also immediately replace and help. And so there may not be a malunion and non-unions. A lot of nano sciences within medicine has also come in. So you could continuously monitor your own glucose. So you need not always, so you know what did you take, and what possibly could be avoided, because your blood sugar rises. I take idli in the breakfast, my sugar rises and it immediately drops. And then it is risky for me. It all could be sort of monitored with continuous monitoring, remote or otherwise. So very, very exciting times. So robotics, just not in clinical work, it is there in operations, it is there in rehabilitation, it is there in diagnostics. So AI, ML, 3D, bioprinting, inking, robotics, mobile health, remote monitoring, wearable devices, good command station based monitoring, preventive health, a lot of information and education going so that you are all aware. So very, very exciting times. We should be very grateful to God that you are in an era where you're seeing both. But it is important that the medicine needs to be practiced in the way it needs to be practiced. Technology is only going to aid or complement your decision making or confirming the diagnostics or diagnosis. It is important that you should have the humility to adopt, to understand what you can do, what you cannot do, or what you could do better. You need to spend time with the patient to hear him out with the complaints with which he has come in. It is important to always prescribe appropriate care. That will only happen once you're updated and you have adequate knowledge. And then technology would definitely also aid. Multidisciplinary and building teams is also important. The isolated practice should not be sort of also encouraged. So all of this is important, but definitely technology is aiding and very, very exciting times. And I'm sure it's going to be wonderful for the patients to also come in and get the best of the outcomes.
Absolutely. And with patients now being more proactive towards their health, as you rightly mentioned, patients are themselves monitoring their glucose level. I see a lot of people on Instagram talking about their CGM levels, how their sugars have gone up and gone down after a particular meal. They're also encouraging other people to also sort of inculcate these technologies in their day-to-day lives. So as you rightly said, technology is going to be there and it's exciting time. Technology is evolving. One thing I particularly felt which is commendable is that Amrita Hospital is also bridging the gap and taking this technology to the future physicians. Thank you so much. Thank you so much for this conversation, Dr. Singh.
Thank you so much. I really enjoyed talking.